Good afternoon. I am Ted Okon. I'm the Executive Director of the Community Oncology Alliance. This afternoon, I'm going to give you an overview of some cancer policy and legislation from the COA perspective, specifically about cancer care during the pandemic. Obviously, to everybody, COVID-19 created an unprecedented crisis. We've seen strains like never before on oncology practices, providers, and staff. And there's been financial strains as well too, but practices have kept their doors open to treat patients. They've had to struggle to keep their facilities and providers COVID-19 free, had to struggle with support staff in remote locations because they couldn't have them on site. And the biggest struggle is treating patients who won't or can't come to the clinics. I think the biggest thing was dealing with the uncertainty of when things get back to normal, or even what normal is after this crisis. Right now, the country is facing a resurgence of COVID-19. It's further straining providers and staff. And there's been a dramatic initial drop-off in screenings that's likely going to occur again. I'm going to show you some slides in a minute, which will really paint a kind of a bleak picture, scary picture. So as of the day of putting together this presentation, October 29th, this is sort of a heat map of COVID-19 cases that Johns Hopkins puts out. Obviously, the darker the color, the more intense number of cases that we're seeing. And if you look at how this has panned out since March and when we started testing, there's basically been three waves. There's one been here in the April time period. There's been one in the July time period. And then there's one in the now that's forming that's even a little scarier. And as of yesterday, there were over 80,000, actually over 81,000 cases of new cases of COVID-19 across the country. I want you to remember that chart. I want you to remember the three waves because it's going to play in next year. There's been a dramatic drop off in cancer screenings. In fact, the Wall Street Journal a couple weeks ago published an article. It was an exclusive on COVID-19 outbreaks led to dangerous delays in cancer diagnoses. And they relied on some data from United Healthcare and Quest. And also we provided the Wall Street Journal with a peak of data that we couldn't even embargo at the time because of study that has since come out that COA has published using data that has been analyzed for us by Avalere Health. And here's one slice out of it. If you want to see more of this study, you can go to the COA website. You can't miss it at www.communityoncology.org, and you can see it, but it's a scary picture. Basically what this does is it looks at the Medicare population and looking at mammograms, colon screening, lung screenings, and prostate screenings. And remember what I just showed you before in terms of the chart. So what you saw here is basically the first wave occurring in April, as I showed before, the second wave in July, so that you see there's been a pickup from April to May, June. Even mammograms were up basically 9% in June, but then you see a fall off again in July. Remember that third wave that we're entering now, and we're very concerned about the impact of that third wave on all these type of screenings. In addition to this, we looked at a number of different things, use of telehealth, basically new patients, established patients, and looked even at biopsies, and you see a very similar picture. So I would highly recommend that you look at that study. It was published in JCO Clinical Informatics, peer-reviewed journal. And again, I think it's some of the deepest data that we've seen published to date. I was a co-author on that study. The bottom line in terms of our COVID-19 update is speaking for community oncology practices. They kept their doors open as hospitals had to deal with COVID-19. Obviously, hospitals have to deal with the primary threat facing Americans, and that is COVID-19 and hospitalizations due to COVID-19. And as a result, community practices saw more patients on a relative basis and use significantly more telehealth than you see even being used in the hospital setting. As I said, cancer screenings dramatically dropped off early with the first two waves. And what we're really worried about is sort of this third wave and a fall off in screenings. Initially, the administration and Congress were very helpful in dealing with financial and operational issues. So the thing here is that if you're going to treat patients, continue to treat them, you basically have to change your operations. You obviously have to have PPE. I mean, it's a very intense process, and you have to sort of re-engineer on the dime. But in doing that, basically, you also have to worry about your financial operations to keep those doors open. So initially, the administration and Congress, through the CARES Act, basically provided PPP loans. There was special provider relief funding from the 10 billion funding for providers. And a big thing, and I'm going to go into this in a little more detail, is remove telehealth restrictions and even increase reimbursement on telehealth. Our focus at COA during the pandemic was, number one, ensuring practices had sufficient financial resources to survive during that initial lockdown phase. No, this is not about money. This is about cancer patients. But the fact of the matter is that if you can't stay financially solvent and basically pay your bills during this, you're not going to be seeing everybody. So we spent a lot of time helping practices even apply for and use PPP loans. The provider relief funds were a really very important source of intermediate funding. And we spent a lot of time with Congress actually in requesting the stop to the Medicare sequester. Those of you who are not familiar, is years ago, basically Congress failed in coming out with a budget, and what went into effect was an immediate cut on all different kinds of government programs, education, defense, and Medicare, and it created a sequester, a 2% cut on all of Medicare. One of the big things was ensuring telehealth restrictions are lifted for cancer patients so they could be screened remotely. And frankly, we had to help patients. We had patients who didn't have the wherewithal, were afraid to get on mass transit, didn't have rides, couldn't afford rides. And basically, along with the fact that people were out of work and couldn't turn on their lights, their electricity, couldn't keep up with their bills, we raised about $2.5 million for two funds that were administered in conjunction with COA, with Cancer Care, a major philanthropic organization. And the last thing, and I'm going to spend a lot of time on this, in the middle of this, you wouldn't believe that we're actually spending time fighting pharmacy benefit managers from interfering with patient care during a pandemic. I'm speechless to when I talk about some of the things that the PBMs are doing during a pandemic, because they basically said, what pandemic? And what I refer to as the PBM insurer complex, what that is that if you look at the top pharmacy benefit managers who control about 85% of the prescription drug flow in this country, they are now basically part of or control three of the top insurers in this country, and they certainly haven't backed off. I'm going to talk about the idea of home infusions, what we refer to as white bagging. I'll explain that, fail first step therapy, and copay accumulators. I know some of this is really wonky if you're not used to it, and how do you understand this? But even if you're a healthcare professional, it's really tough to understand. But these are the kind of things that we have to deal with. And you would think that during a pandemic, especially with the insurers making money, profits, hand over fist, that they would not be in a position to basically put the screws down that really get in the way of providing optimal patient care. So I just want to show this. The world used to be simple. You basically had your physician practice, your patient, your pharmacy. I'm leaving the hospital out for now because that's sort of tied to the provider side. And the pharmacy would get its drugs from the manufacturer. And you'd have a flow of basically communication of dollars would flow, and you would have the flow of drugs. I try to draw a picture of a simple picture of what it looks like now. And this is the simple picture. And I'm not going to go through this in the interest of time, but basically what you have there is you have just increasing complexity of what's going on. And you have things like white bagging, which I'm going to talk about, rebates flowing. You have these copay drug assistance, and now these accumulators. I mean, it's just a really complicated thing. And what's really interesting about it is if you take the PBM, their specialty mail order pharmacy, if you take the health plans, more and more, they're one entity. They're under one corporate entity. And then when you turn around and you basically look at also under those entities are pharmacies. So CVS, for example, owns pharmacies. That you're probably used to seeing CVS and owning pharmacies across the country, not knowing that they have a PBM, a mail order pharmacy, and also are a health plan because they now own Aetna. And you have entities like that even go further, United Healthcare, that owns some 40,000 physicians. So it's a big deal here in terms of the consolidation and the vertical consolidation and how it's complicated the system here with a lot of middlemen. How I view our healthcare system is it's unduly complex and convoluted. It's packed with middlemen that siphon off profits and increase cost of drugs and services. There's really been a race between the middlemen and the providers in terms of who can consolidate the most. So, you have basically these middlemen that have the PBMs are consolidated basically with as I just showed, with the pharmacies and with the insurers. And of course, you have these health systems that are getting, just this week, heard more things about health systems that are big health systems that are combining. So it's been a real race, and it's continued to be a race. I basically look at this and say there's really been incompetent federal policy that's fueled the consolidation. And if you look at that system, there's nothing like it in the world. I'm not letting drug manufacturers off the hook for pricing. It's a real big problem. But drug pricing in this country, there's a very big difference, and there's a growing gap between the list price and the net price of the drug. Whereas if you look at every other country in the world, what you see is the net price. Why? Because you don't have all these middlemen. You don't have this convoluted system. In fact, if I really had to sit there and give you sort of just a picture of how convoluted this is, and all told, not in my simplistic thing, this is what it would look like. I mean, it is just so convoluted, it's ridiculous. And when you have a pandemic happen like, once in a century, like we see, then what happens is this convoluted system. It is really tough to navigate, especially when you talk about cancer care. So I'm going to give you a little bit on telehealth, and then I'm going to go through some of those PBM issues, because when you look at what we've been doing from a policy standpoint and what we've been also doing from the standpoint of keeping practices open, their doors open, being able to treat patients, this is some of the things that we've been dealing with. So I think a lot of people know that prior to COVID-19, telehealth was really rarely used. In fact, what you had to do is you had to be in a rural area. The provider had to be in a telehealth facility. The patient had to be in a telehealth facility. That doesn't make any sense at all. The whole idea is to have that patient remotely. So it's very, very restrictive, and it was really just tough to use. And frankly, the reimbursement wasn't even close to any kind of, parity with health visits. So we lobbied very hard, as other organizations did too. But we pushed very hard to remove telehealth restrictions, expand the use, and increase the reimbursement. This all happened as part of the CARES Act, and some regulatory action that HHS and CMS took without any laws. Additionally, we had to have HIPAA waivers for providers when you're using non-HIPAA compliant technologies like FaceTime, Google Hangout, Zoom, and Skype, all those kind of things that were used for telehealth, in addition to actual telehealth apps. So the result was widespread adoption of telehealth in cancer care, especially among community oncology practices. It was kind of amazing, especially during the early stages of the pandemic. And, it was great for use in patients not wanting to leave home, patients in the middle of, not in the middle of treatment. And actually for patients, I know a lot of oncologists have said, look, the type of cancer, the type of the drugs that you're on, the regimens basically allow you can skip a cycle. And so it's been very helpful and been very good. Obviously, oncologists will tell you that it's not a substitute for having that patient right in front of you, but it's been important. And but it's had some limitations. I mean, one of the things that's really been amazing is that we've seen where we have broadband access problems in this country. In fact, not only in rural areas. And it's been interesting because along with homeschooling, there's been a realization that there's a real broadband problem. And I'm really hopeful on a bipartisan basis. This usually doesn't happen, but it's moving that way, that this Congress, if it doesn't happen by the end of the year, it happens in the next Congress, passes legislation on broadband access. I know some members that I've talked to that are working on that. Not all patients have access to smart devices. So, and those that have them are, some people who are older don't even know how to use them. So that's been a problem, although there's been the lifting of it so that you can have audio only, not just visual. And, there's been patient limitations of using some of these HIPAA compliant telemedicine platforms. So, more people, even grandparents have gotten used to basically Zooming and keeping in touch and all that. But with some of these telehealth compliant platforms, it can be a little difficult. So there's limitations. And, from the oncologist perspective, I've heard this is time consuming. It's not the fact that you walk into the basically exam room, the patient is set up, you have everything in front of you. It's a very different process. And it is staff intensive. It's less productive than office visits. You have all problems with scheduling, but it has been helpful. The telehealth app doesn't always communicate or link with the EHR. That's a big problem. And there's a question about the lack of clarity around telehealth use across state lines. Can you do it? How does that work? Because state laws are driven by where the patient resides. So at COA, we have a government affairs committee, and of course we have a board. Our bottom line is that the use of telehealth can't go back to what we refer to as BC, before COVID-19. This is actually a statement that appears here. It's up on the COA website. You can see all of our policy statements that are approved by our GAP committee and then our board. And we don't believe that telehealth should be restricted to facility use. HIPAA limitations need to be overcome, and reimbursement needs to be realistic here. The other issue that we've had to contend with is home infusions. It's not only been pushed by some of the insured PBM Complex, but home infusion advocates, even some pharmaceutical companies, about moving to home infusions of physician administered drugs during the pandemic. There are certainly some drugs that can be administered via home infusion, either an agency or somebody coming in. But when you talk about cancer drugs, and I'm married to an oncology nurse who spent 10 years being an oncology nurse. And when I first started talking about this, she said, you got to be kidding me, because you have any kind of adverse event and adverse reaction, and the first thing that happens is you call your nurse team in, you have a physician on site. God forbid you have a code, you have procedures in there. So the idea of basically not having the equipment, the oncologist on site, and the nurse, and whether it's a nurse from the home agency that you can't guarantee is an experienced home nurse, or it's one of your own, the bottom line is you don't have all the support. So we're very much against this, and it's a problem. And there's all kind of problems. How do you store the drug, the transport of the drug? What happens if all of a sudden the oncologist, it changes basically the regimen, and the regimen is already mixed up, and that's what you're bringing in. So you're looking at waste. Who assumes the liability? I've had more oncologists say, who's supposed to assume the liability of us? And, and frankly, it opens up the door more to the PBMs in terms of, and the insurers in terms of not only dictating where care is given, but what care is given. So it has a lot of problems associated with it. One of the other things that we've dealt with is something called white bagging. As you can see here, this is pretty much literally it, is that this is a case where the insurer, the PBM, basically says, I'm going to deliver the drugs to you, hence in a white bag, versus brown bagging, where it goes to the patient, for the patient to bring into the clinic to have the clinic administered, which is just really crazy. But this comes in and basically we see white bagging with specialty drugs breaking out all over the country. Expect the insurer PBM complex to increasingly sell white bagging to employers as a solution to lower specialty drug costs. That's so far from the truth. What they want to do is use white bagging so they can basically make more money on these drugs. And the insurer dictates what drug is going to be used, and a PBM dictates where and how the drug is delivered in terms of that. So this is a top priority for COA to fight. We have come out with a statement on white and brown bagging, again, from our GAP committee and our board of directors. And in addition to that, we've worked with our attorneys to basically provide practices with a very, very, very thorough letter that basically says that from the practice, we're not even having a discussion on white bagging until you answer the following questions and basically verify the following information. And because what it does is it throws the liability back onto the insurer, which of course the insurer doesn't want. So this is a very big deal. This is very scary. It's very scary for cancer patients. If you've ever basically gone to a specialty drug, one of the big specialty drug wholesalers and distributors, and you look at track and trace, you know exactly where that drug is coming from. Once it gets out of your hands and system by having some intermediary middleman basically distribute those drugs, it is a scary proposition. I wouldn't want to be a cancer patient and getting chemo or some IO drug that's been white bagged. Fail first step therapy. It's called step therapy. We all refer to it fail first. Why? Because the patient has to fail first. They basically don't. They basically are. Typically, they started out with having less expensive drugs like generics be used before the brand. So you had to fail first on the generic before the brand. And this is now morphed into the PBMs and the insurer complex of literally forcing the most profitable drug for them. We had a payer summit over the last couple of days at COA, a virtual summit, and people talked about this, that in the case of biosimilars, we've seen that you have to fail first on the originator product before you're given the biosimilar, which is the less expensive product. I mean, this has just gotten way out of control in terms of what step therapy is meant to be. And we again have a statement out on the COA website that was passed by our GAP committee and our board on fail first step therapy. And a very interesting case that's come up during the pandemic is this case dealing with iron therapy. And it's amazing that United Healthcare has basically forced the fact of using an iron therapy that basically requires the patient, in this case, we found that United Healthcare step edit is incentivizing the use of drugs that require between 5 and 10 administrations over a longer period of time for a course of therapy, in contrast to 2 doses within 1 week for the treatment options that have been restricted. So imagine during a pandemic, we now have a wave, and basically you don't want to have people travel. You don't want to have people come in excessively into the clinic in a medical situation. And that's exactly what United is forcing. So these are some of the things that we're seeing out there. And it's just, again, scary. So it's a big fight. And in the middle of the pandemic, when you're trying to keep patients treated and keep your facility, keep your providers, and try to streamline what has been overly complicated, this gets it even more complicated. The last thing is that I referred to is Copay Accumulators. And this is about a little wonky, but basically what it means is that, as you know, a lot of patients out there can't afford their copays, and they're giving copay assistance. This is a situation of where basically the insurer is saying, hey, when the patient gets any kind of assistance, we don't want it to go to their deductible. So what does that mean? That means that the patient isn't going to get the ability of having that copay assistance take care of their deductible. That's exactly what you want to do. These are people who can't afford their deductible. So who gets the benefit of this? It's, in this case, United Healthcare, that is forcing that not only is this copay accumulator going into effect January 1, 21, but what happens is they're requiring that the physician do the monitoring and be the police reporting back to United that this patient got copay, and it's beyond belief in a normal situation, let alone in the middle of a pandemic. So once again, we have had our GAP committee go through the copay accumulator programs and basically issue a statement that our board approved on this. And it is just a really crazy situation. We have sent a letter to Seema Verma, who is the administrator of CMS. Basically, when CMS came out with some proposed rules dealing with this copay accumulator program, we hit the warning light. This was back in July, of saying, basically, don't let the door open, because if you do on this, the insurers will come because they see money to be made basically off of the back of patients. So instead of the patient getting the advantage of having their deductible down, that deductible, which gets paid to the insurer, and that's the insurer that during this pandemic has made, but this United is one, has made money hand over fist, is basically, it's pure greed. And as you have more patients in need, literally you have patients who are unable to afford their medications because it doesn't go to their deductibles, even they're getting assistance. So this is just deplorable that this is happening at any time. But certainly during the time of this pandemic. I can't even begin to talk about this. What else? There's a lot going on. 340B drug discount program. The courts have allowed CMS now to continue 340B reimbursement cuts, even lower than before. President Trump signed an executive order on 340B that basically allows the discounts not to go to the institution, but directly to the patient for two types of drugs, insulin and epinephrine. And basically the companies now are pushing back on these contract pharmacies. I know this sounds very wonky, but the problem is, this is a little program back in 1992, was meant to help some facilities, help safety net hospitals, help patients in need. And this thing has mushroomed now to half of the hospitals. The discounts don't go to the patient on these very expensive drugs like cancer drugs. They go to the institution, to the hospital, and it's a real problem. And now these hospitals have added these pharmacies on that basically provide these discounts, and not to the patient. There's pressure to eliminate PBM rebates. There's a district court hearing on hospital billing disclosures, meaning hospitals would have to disclose their billing. Supreme Court hearing is on the ability of states to enforce PBM restrictions and provisions. That will be decided by the Supreme Court, as well as the case that you probably heard with the confirmation of Judge Amy Barrett, hear the case on Obamacare. That's coming up. And just today, CMS, HHS announced insurer transparency. So just like that, the hospitals have to be transparent, the insurers have to be transparent. In fact, by 2024, you'd have to see your bill before you even get it for a procedure. And there's so much more, but time has run out. So I'm gonna put up for a minute my contact information. If you have any question, there's my cell phone, there's my email. I keep my contact open to everybody. That's our site, as I said, communityoncology.org. and I am on Twitter at Ted Okon COA. So I thank you for listening to me. I hope this wasn't too wonky. I know there's a lot there to digest, but if you have any questions, give me a holler.